This is a recorded lecture on Chapter 5, Humerus. This begins in your positioning book on page 177. When we look at a humerus, this is the first exam with upper extremity that we actually will move into the bucky, because now our part is typically going to be greater than 10 centimeters. So we have to move from tabletop to bucky. When we look at the shoulder girdle, which is in this chapter, notice it's made up of the clavicle, the scapula, and the humerus. All three of those compose the shoulder girdle. So you've got the clavicle, the scapula, and the humerus that make all of that up. When we look at the proximal humerus, the view of this is on page 178, figure 5.2. We have all kinds of anatomy that is important to the proximal humerus, which comes into play a little bit more when we talk about shoulder, but regardless, when we get humerus, we have to get both joints since it is a long bone, and this would be the proximal aspect. So notice we have the greater tuberosity or the greater tubercle. We also have the lesser tuberosity or the lesser tubercle. In between the two, we have the intertrabecular groove or bicipital groove. The humerus has a surgical neck and an anatomic neck. You've got the humeral head, which sits in the glenoid cavity of the scapula to form the shoulder joint. And then you've got the deltoid tuberosity on the shaft of the humerus, and then this is the body or the shaft of the humerus, which would continue down to the distal aspect. When we look at this radiographically, because you want to try and correlate your anatomy from a picture in a book pointing out what the anatomy is to the actual radiograph itself. So notice we've got the clavicle here, we've got the acromion process of the scapula, we've got the coracoid process, we have the glenoid cavity or glenoid fossa, and this is where the humeral head sits to form the shoulder joint. And then they outline the greater tuberosity and the lesser tuberosity. And remember, in between the two, you have the intertrabecular groove. So this is actually, again, looking more at the shoulder when we get to talk about that. But right now, we're going to focus on the humerus. The humerus is only two views since it is a long bone. We have to include both joints of the humerus. So you have to include both the shoulder and the elbow joint, because any long bone you have to include not only the entire long bone, but the joints at both ends of the long bone. And when we talk about positioning of the humerus, it begins with the AP, which is on page 187. And notice that this is the picture in the book that they show you. Okay, so we'll start with that. Typically, you're going to use a full-length IR, so typically a 14 by 17 lengthwise, or a 16 by 16 if you're on a digital receptor. The technique for this would be 75 kVp at 3 mass. And notice that they have the patient standing erect. We also can do the supine, but typically the patient is much more comfortable when they're standing erect because they don't have the pressure on their arm like they would if they were lying down. The next slide, I'll show you them. We can do it lying down, but typically if they're able, upright is much easier on the patient as well as us. You can shield the patient for the images for both the AP and the lateral. But the patient is going to stand erect at the chestboard, and you want to adjust the height of the chestboard or the wall bucky so that you're able to include the shoulder comfortably. You're going to abduct the arm slightly and supinate the hand so that the epicondyles of the elbow are parallel and equidistant from the IR. Now, if you look at this image, I don't know all the patients I've ever done. I find it very difficult if your arm is injured to keep your arm right by your side like that and supinate the hand. Notice her palm is out, so her hand is supinated, and then ideally her epicondyles are parallel from the IR, parallel to the IR and equidistant. Typically, it's a lot easier to have the patient abduct their arm I would say approximately this much. So I went and found this picture for you guys because typically when we do an AP humerus, this is more what it looks like versus this straight down by their side. So again, arm is abducted, the hand is supinated so that the epicondyles are parallel to the IR, and central ray is mid-humerus, which would be midway between the shoulder and the elbow joint. You just find the midpoint of that. Now, find it initially, your IR is going this way. So what we can do is when the arm is abducted like that, we simply turn the tube head to align with the long axis of the part so that the long axis is, this line is running down the long axis of the arm, of the humerus. And then you're simply going to collimate side to side on this. You're not going to collimate anything top to bottom because you don't want to clip the elbow and you don't want to clip the shoulder. So you're simply coming in from side to side because we don't need it very wide open. Again, central ray is midpoint of the humerus, and you want to make sure your marker is included and in the light but not in the shadow of the part. Typically, when you do this, you will demonstrate the entire humerus, including the shoulder joint and the elbow joint, and you want to make sure again that the epicondyles are parallel to the IR, so the hand is supinated, and you're going to turn the tube to go with the arm. Now, if the patient were lying down, this is what it would look like. Again, more comfortable when they're upright because they don't have the pressure of their arm lying on the table. But if their injury was such that they were not able to stand up, you certainly could do it like this, doing the same thing, abducting the arm slightly away from the body, supinating the hand so that the epicondyles are parallel to the IR, which is then underneath in the table bucky. Central ray midway between shoulder and elbow joint. When we do this, whether we do it upright or supine, as far as the evaluation criteria, you have to demonstrate the entire humerus, including the shoulder joint and the elbow joint. The greater tubercle is in profile, which is here. The medial and lateral epicondyles are in profile. And as far as exposure factors, again, we use 75 kVp at 3 mass, and this is actually proper penetration. You can see the bone, you can see trabecular patterns in the bone, you can make out soft tissue, but you're not overexposing the bone or penetrating it too much so that it's dark. This is actually a very good exposure. So that's our first image. That is an AP humerus. And then again, if we look at this just in a little more detail compared to what the picture in the book is, notice you can see the acromion process of the scapula. You can see the humeral head outlined, the glenoid cavity of the scapula as well. You can see the greater tubercle and lesser tubercle. And then in between, it's not labeled, but we have the intertrabecular groove. We have the surgical neck here. The anatomical neck, again, not labeled, but it would run right here. You've got the shaft of the humerus, and then the deltoid tuberosity where the deltoid muscle attach. Down at the distal aspect of the humerus, you've got the lateral epicondyle and the medial epicondyle. You've got the trochlea, the capitulum, and then the capitulum articulates with the radius, and the ulna articulates with the trochlea, and that's what actually forms your elbow joint. So you've got elbow joint included, shoulder joint included, and the entire aspect of the humerus included. And notice how this image shows it a little bit where it's abducted slightly. The IR probably ran up and down, but this image runs diagonally so that you're capturing everything, but you're not forcing the patient to keep their arm straight down by their side. Again, if we look at this, this is an AP of the left humerus. The marker is lateral to the part. The arm is pulled away or abducted from the body slightly. And notice the epicondyles are parallel to the IR. You can tell they're parallel because you can see the joint space between the radius and the ulna. You can see a nice open elbow joint space, and nothing is elongated or foreshortened in the distal aspect of the humerus. And again, up here you can see the greater tubercle in profile and a nice image of the AP humerus. Then we move on. Our second view is a lateral humerus. Okay, and this is on page 188. And there are multiple views that show a lateral humerus, but the one that we're going to focus on is this right here, which is called a lateral medial projection. So the patient is actually facing the IR, and this is figure 5.31 in the book. This particular image here, she is just simply turning her hand in figure 5.29, and then there's another one, figure 5.30, which is actually this picture right here. Okay, so there are multiple ways to get a lateral humerus, but this is the particular image that we are going to do on our patient if they are able. So with the lateral, what you're going to do is still a 14/17. You're going to turn the patient towards the IR, and you're going to oblique the patient as much as you need. Typically, it's 20 to 30 degrees from PA, and you want to keep their humerus in close contact with the IR, and you want to flex their elbow 90 degrees. Okay, their palm also should be up for this particular image. So most of the time when we do this, honestly, if we have the elbow flex 90 degrees and their arm back, typically their arm will come like this, and then with the elbow flexed, their arm will come more up this way, and the palm will be in front of their abdomen, and again, it's palm up for that particular view. When we do this and the palm is up, then the epicondyles are actually going to be perpendicular to the IR, which is what they're showing you right here. So in the AP, they were parallel, but now they're going to be on top of one another and perpendicular to the IR. Your central ray doesn't change. It's still mid-humerus, so midway between the shoulder and the elbow. Again, with the arm pulled back like this, you simply find midway. And this, you would align this before you turn the tube head. So after you did the AP, you would have to go back to straight up and down, turn the patient, oblique them, bring their arm out and bend the elbow and find the middle, and make sure you are lined up with the middle so that your Q is aligned to your tube, and then you can turn your tube head and simply collimate from side to side. On a true lateral of the humerus, it's evidenced by the epicondyles being completely superimposed. The lesser tubercle is shown in profile medially, and ideally you have good collimation on there. Okay. The reason we prefer to do figure 5.31 is because it shows the elbow at a 90-degree angle with the palm to the sky, and all the other laterals, all they're simply doing is internally rotating the arm to bring the epicondyles perpendicular. Okay, so if the patient can't bend their elbow, then this is what we would do. So she's simply standing up, internally rotating her hand so that the dorsal surface is against her thigh, and that would make her epicondyles perpendicular to the IR. So this would work, as well as this particular image where she's lying down doing the same thing. The epicondyles would then be perpendicular, which would place the humerus in a lateral position. So this is a lateral recumbent humerus, and this would be an upright lateral, simply by internally rotating the arm. Okay, so it seems a lot easier on the patient, but the problem is, if you can, you much prefer, and the radiologists prefer, a 90-degree bend in the elbow so that they can evaluate that along with the humerus. So this is our lateral humerus. If they're lying down and unable to stand, same thing, you internally rotate the hand so that the epicondyles become perpendicular to the IR, and that would also give you a lateral humerus. When we look at the evaluation criteria, notice again we see the entire humerus demonstrated. We see the shoulder and the elbow joint. The epicondyles are perfectly superimposed right here. And as far as exposure factors, again, you can make out soft tissue, bone trabeculi, see that at a perfect 90-degree angle. Nothing is overexposed. Okay. So again, typically the one that we would prefer to be is this image right here. This one, and with the patient lying down, just simply internally rotating, is more if the patient is unable to bend their elbow. They're also, in certain trauma situations, the patient might not be able to do even that. So we can do a lateral, a trauma horizontal beam, or a cross table lateral. This would get the lateral mid and distal portion of the humerus. So if the patient's unable to do much of anything, you simply could place the IR in there and shoot a cross table lateral beam, which would give you a lateral image of the distal aspect of the humerus. And radiographically, it would look like this. So again, you get the mid and distal humerus. It's a 90-degree perspective from the AP view. The epicondyles are still superimposed, so it is still technically a lateral, and you've also got a 90-degree bend in the elbow. So if the patient is unable to perform the lateral we prefer, or the radiologist prefers, this would be a good position for the mid and distal portion, a cross-table lateral humerus. Okay. And then we also have, a lot of times in the trauma situation on page 190, we do what's called a transthoracic lateral, where you're going through the thorax of the patient with a horizontal beam. And this is typically done when the patient is unable to move their arm. So with this particular image, this patient would have injured her right arm. So notice we're still going to demonstrate the entire humerus through the thorax because this beam is a horizontal beam. So she's raising her left arm up out of the way so that we can get an unobstructed view of the right arm through the thorax. Now when we do this, typically, again, we're on a 14x17 lengthwise. The difference with this particular image and what we do is that we usually use what's called a breathing technique or an orthostatic technique, meaning that you typically use a minimum of a 3-second exposure time, and you have the patient breathe normally while you're taking the x-ray. And what this does is allow the lungs and the ribs to be blurred from view so that you can see the humerus through the thorax without the obstruction of the lungs and ribs in the way. Now, it doesn't get rid of them completely, but you'll see when I show you the image that you get a really good, clear view of the humerus by allowing the patient to continue breathing normally. So you try and stress to them not to breathe deeper, not to breathe more shallow, just to continue breathing just as they are. But when you set the control panel for a breathing technique, you typically choose a low MA station in a longer period of time, anywhere between 2 and 4 seconds. I know the book says 4 to 5 is desirable, but that really is a long exposure time. So ideally somewhere between 2 and 4 second exposure time. So we place the patient's affected arm at their side in a neutral position. You try and have them drop their shoulder if at all possible, but a lot of times with a humerus injury, it's already dropped. They're going to raise the opposite arm up over their head so that it's out of the way, so that you don't get any superimposition from this arm over the affected arm. Again, you would have the patient just tell them to continue to breathe normally. You can shield the patient. And it says that the central ray is to the mid aspect of the involved humerus. So what you pretty much do is look at the affected humerus, find about where the center is, direct the central ray to that area. They show you with the patient lying down as well if she's unable to stand. Same thing, affected arm against the IR, raise the unaffected arm, and just kind of center to midline of the humerus. Radiographically, this will come out if we use this gentleman as an example, just like the lady in the last picture. Okay, so same kind of positioning. This is not in the book as well, and I wanted to make sure you understood. So horizontal beam coming through, this is the affected shoulder. And then notice how you can see, you still see ribs, you can still tell there's lungs there, but because they're breathing, what happens is this humerus shows up nice and clean through there. So spine, rib, lung detail, but because they're breathing, you can get an unobstructed view of the humerus much better when they use that orthostatic breathing. That's just a really good picture. A lot of times these come out very nice, and which is a good thing for the patient, because typically, like I said, that they're in a lot of pain with this, so it's difficult for them to move that arm. So if you can achieve this without them moving, much better for your patient. Okay, and that is a transthoracic lateral of the humerus. Again, humerus is two views, AP and lateral. The technique is 75 kVp at 3 mass. With the AP, the epicondyles are parallel to the IR. With the lateral, the epicondyles are perpendicular to the IR. And as with any long bone, you have to include both joints at either end of the bone. If you have any questions or comments or things don't make sense, make sure you write those down. And the next time we meet, we will discuss and I will try to clear that up for you. Until then, take care.